Go ahead, Summer.
All right, so today's case is about a Caucasian male, 52 years old, who presented first to the PCP for a regular checkup with 3 months of intermittent gross hematuria.
All right, is this a good place to start or to stop?
Yep,
Oh, wonderful. So we have a chief complaint of intermittent gross hematuria. So when I think of hematuria, a couple of things that would be helpful to get more clarity on before coming up with a differential diagnosis. Especially in the 52-year-old male, a couple of things that I would be thinking. First, if there are any medications on board that would make someone more prone to bleeding, right? If he's has AFib and on any anticoagulation. So one thing that is always good front and center to think about like a medication list of anything that could be contributing. And the other one to also think about is like any underlying hematological disorders that can make someone more prone to bleeding. So, because whenever I think about like anemia, acute anemia, urinary source or hematuria is one of the ways people can lose a lot of blood. So one thing to think about is like, again, like, is it something more systemic going on, or is it something localized to the genitourinary tract that we need to pay attention to? So those are kind of like the two big branch points that you want to think about: systemic issues, and then anything more prone to the genitourinary tract. And what are the components of our genitourinary tract? And in a man would be the kidneys, the ureter, the bladder, the urethra, prostate. So thinking about any pathology at any of those sites that can lead to gross hematuria. A lot of the times, any big lesions, again, we often deal with like microscopic hematuria, like in a setting of a kidney stone and infection. But when it comes to gross, really thinking about lesions or anomalies that can cause gross hematuria, like any lesions in the bladder specifically, in the kidneys that can cause gross hematuria. So I'm excited to learn more, Summer, about this case.
so further questioning by the PCP, by the patient's PCP, also revealed occasional right flank pain, but the patient denied fever, weight loss, and any lower urinary tract symptom.
All right. Do you want to give us a little bit more information, maybe until the physical exam?
Sure. So I'm gonna move on to the past medical history, and the patient has hypertension that is controlled by lisinopril, 10 milligrams per day, and has been on lisinopril for 3 years now. And the patient has no prior surgeries, no prior malignancies, and no known drug allergies. And lisinopril is the only medication that he is on.
Uh, all right. So, and further clarification, we get a history of that patient's having right flank pain. And oftentimes, when thinking about right flank pain, we think about what's there, in terms of like kidneys being kind of the most the organ that comes to the mind, especially if you're thinking about someone who's coming with gross hematuria and has like flank pain. It really, really prioritizes any kidney issues that is going on. So when we think about like the kidney itself, thinking about so let me pause there. So again, we're thinking about gross hematuria, intermittent gross hematuria in someone who's coming in with right flank pain without any other systemic symptoms, right? We don't hear any about weight loss or any other localizing symptoms. One thing that, also I want to make sure to think about whenever I'm evaluating someone with hematuria, are there any mimickers of hematuria that you also need to worry about? So the mimickers of hematuria are often in a woman, especially, not this patient, but a woman would be like vaginal bleeding that can at times get mistaken with hematuria, something to be aware of. And then the other mimickers are the pigments that can make the urine look like a color that it might be old blood, like rhabdo in the form of myoglobin, hemolytic anemia in the form of hemoglobinuria, like porphyria, anything that changes the color of the urine, a patient might assume that it's blood. So that's something to keep in mind as we're thinking about evaluation of someone with hematuria. And my favorite, honestly, is beet ingestions that sometimes can change color of the urine as well. So first, thinking about the mimickers of hematuria, and then thinking about further whether especially when we're invoking with the flank vein some sort of kidney involvement, then we really think about like whether this could be glomerular bleeding or a non-glomerular kidney bleeding, right? And a lot of the glomerular bleeding are often mostly I associate with microscopic hematuria, not as much macroscopic. So whether it's any like your immune complex mediated anti-GBM, all the auto like immune mediated stuff tends to be glomerular, and I often think more as a microscopic rather than macroscopic gross hematuria. In terms of a non-glomerular kidney involvement, pyelonephritis, again, we think more about microscopic unless there is a lesion there. RCCs, renal cell carcinomas, sometimes like with polycystic kidney disease, you can see it as well. But most often, these things tend to be microscopic. But however, bigger lesion encasing a blood vessel can definitely cause some gross bleeding. Oftentimes, when it comes to gross hematuria, though, the lesion tends to be more within the bladder, to be honest with you. So sometimes like the stones or urothelial cancers, and with gross hematuria, I often really do worry about cancers most often in the bladder are the ones that I would be most concerned about. Um, and then, like in younger adults, you often hear about exercise-induced hematuria as well, which often presents much younger in age. So, in someone and looking through kind of the past medical history, I don't really see any, as we mentioned, like any causes of systemic that is to be identified, right? This patient is not on any anticoagulation. He takes lisinopril that often we think about can be invoked in like AKI, but not really in bleeding. And in terms of like social history, the other thing, thinking about smoking, at times put you at higher risk of cancers, which we don't see here either. So on and all, the question is like, what are we gonna do next? First, a good exam, because again, you want to make sure this has been happening for a few months. So making sure, again, with gross hematuria, you have to worry about anemia. And if there's any signs of anemia, or any signs of hemodynamic stability that requires more urgent follow-up. So making sure to do a good exam, abdominal exam, like making sure to both back flank exam to see. Sometimes like the masses can get pretty big, but oftentimes not palpable. And again, like thinking about what other etiologies that are common, making sure to evaluate for a urinary source of infection, and also, a thorough exam to make sure there's no other signs of bleeding. Would you see any petechiae, any other clues as to we tie this to a more systemic rather than a local issues? Because for now, based on the history that we have, we really hone into the genitourinary tract rather than this being a more systemic manifestation. And yeah, so I'm excited to hear what you saw on exam.
Yep. So on physical examination, the general examination reveals a pleasant man who is oriented to person, place, and time, and can hold a normal conversation. Vital signs were normal. So blood pressure was 131/84. The respiratory rate was 15 per minute. The lungs on auscultation were clear. And on heart or cardiac auscultation, heart rate was 78. It was regular, no murmurs, no rubs, no gallops. And more importantly, on abdominal examination, the abdomen was negative for tenderness on palpation, negative for hepatosplenomegaly masses, and renal brie. And the patient also had normal bowel sounds. Neurology-wise, the patient had normal reflexes, motor strength, and sensation in all limbs. And finally, extremity-wise, the patient had no extremity edema.
All right. Thank you so much for that comprehensive exam, Summer. So, vital signs being vital, a patient is afebrile, now tachycardic, blood pressure in the 130s range. Again, you all heard me say this many times. With medicine in general, what you really care about is the delta, right? So, we have this range of what is normal, but what is normal for every patient is different. So, if this is a person who is really severely and always lives in the 200s, coming in 130s might be abnormal for that patient. But in general, like if someone with history of hypertension on a medication and a blood pressure of 130s, sounds like they're at their baseline, but always double check and especially if someone that you have more data in your system for, definitely making sure you trend those vital signs and look back. But other than that, this patient seems stable in clinic. The other things that is worth asking about is, especially if you're worried about gross hematuria leading to anemia, is like orthostatic symptoms, like if they get dizzy, more fatigue, those things can help help you figure out how urgently you want to evaluate someone. The exam is like relatively, as we suspected, benign in nature, right? We haven't found any other signs that that would makes us more worried about a systemic bleeding, and everything basically is within normal limit for this patient. So then the question becomes like, what to do next. So we have a 52-year-old with history of hypertension who is coming in with intermittent gross hematuria and right flank pain with stable vital signs and a non-focal exam. And you're seeing this patient in clinic. If the patient is hemodynamically stable, but the fact that this has been going on for a few months, it really requires more thorough workup. So where do we start here? So getting your basic labs, so getting CBC. Again, do you think about your systemic signs of bleeding? So making sure the platelets are okay, taking a look at the hemoglobin, and also your INR to think about like the coagulation cascades. And then the other thing something that, oftentimes we get to do in urgent clinic is just to do a UA and to see if there is any signs of bleeding currently. Chances are, if he has intermittent gross hematuria, there might be some microscopic hematuria, even if he's not having bleeding at that time. But again, because the history is intermittent, there is a chance that your UA might be completely normal. However, if there's any signs any signs that this is actually has been history of gross hematuria, you still need to work it up. Then the question is like, what type of imaging would we want to get at this point? And that is kind of will help dictate. And it's that your pretest probability of where the lesion is at in your genitourinary tract will help dictate what you want to get, right? So if you're more worried about a kidney ultrasound would be a good start. If you're more about a bladder, oftentimes these people require cystoscopy and urologic urologic evaluations. So, or like a CT abdomen pelvis with contrast. I think ultrasound of the kidney, especially with that right flank pain, might be a good place to start. So like, and the other things that it also can help you with is, again, like stones I don't often associate with macroscopic or gross hematuria, but you can see stones. You can take a look at the parenchyma of the kidney as well, any signs of hydronephrosis, sometimes masses. And then if that is negative, thinking about a cystoscopy or a CT abdomen pelvis that can help look for masses. If you ask me, I would get the basic lab and maybe start at a UA and an ultrasound. And we really haven't gotten any symptoms of infections, and it's been going on for a while. So I'm like less concerned for this being a urinary source of infection. All right, I just talked a lot. Summer, please give us some more information.
All right, so let's get to the labs. Hemoglobin was kind of elevated at 17.4, but hematocrit was normal, high 40s, 49. White blood cells were normal, 5,200. Platelets were normal in the mid 240,000s. ESR was normal, and electrolytes, including sodium, potassium, chloride, and bicarb were all normal. So sodium 143, potassium 4.7, chloride 101, bicarb is 28, and BUN was 21. Creatinine was 0.98. Albumin was 4.1, and glucose was 96. Calcium was 9.1. And liver function tests were all normal. So ALK was 93, AST was 35, and ALT was 31. And I don't have enough in front of me the coagulation studies, but yeah, I remember that they were normal. There was nothing special about them.
Wonderful. Thank you so much, Summer. It's getting more and more interesting. I think Jack is here. Hey, Jack.
Oh, sorry to be late, everybody. Sharmin, it looks like you're crushing it already with this case, so it's good to get to join in.
No, it's not the same without you. So let me give you a quick summary, and then let me know if you want to comment on anything or you want me to talk about labs initially. So this is, we have a case of Summer presenting. He's a 52-year-old gentleman who came in with a few months of intermittent gross hematuria and right-sided flank pain. No significant past medical history other than hypertension. Exam was fairly unremarkable. And so we had a chance to talk about hematuria and growth hematuria in particular. And here we have the labs. Do you want to take the labs? Do you want me to first comment on it? Whatever you prefer, friend.
Go for it. Yeah, you've already done so much in the case. Go for it. I'll get caught up as you're talking and see if there's anything else, and then I can jump in.
Okay, sounds great. So, looking at the labs, super interesting. So the things we talked about, right, with someone with like gross hematuria, we often worried about anemia, and look at that hemoglobin of 17.4. Fascinating. We'll come back to that. But the other things we wanted to look for, the platelets are within normals, coagulation cascade. So again, our focus remains in the genitourinary tract and what could happen there. So let's talk about that elevated hemoglobin, and I'm thinking about polycythemia. So whenever I think about polycythemia, one, you can always invoke whether it's a mimicker, like if this is dilutional in general. So a lot of volume loss that have led to dilutional. 17.4 is a bit high for that, especially in someone that you're worried have a source of bleeding. So I'm gonna assume this is real. So whenever I think about that. I think about, what EPO-mediated and EPO non-mediated processes. And a lot of the times when we have polycythemia, the first thing I do with common things being common, I think about chronic hypoxemia, and oftentimes, OSA, OHS, that oftentimes lead to polycythemia as a compensatory measure for chronic hypoxemia. And then I think about hypovolemia as we think about, again, common things being common. And then I think about substrates, right? EPO, androgen, sometimes take too much testosterone. And here, I'm pretty much fixated on EPO. And thinking about, someone who's coming with gross hematuria, with flank pain, and polycythemia really, really makes me worried about an RCC that can cause that as part of RCC can produce elevated EPO that stimulates the bone marrow that can cause elevated hemoglobin. But not to anchor, oftentimes then the other things that you want to think about in terms of polycythemia are your MPNs, myeloproliferative disorders and neoplasms, polycythemia vera being a big one that we often think about, and an ectopic EPO, as we talked about in cancer as well. So what would I do? So how about I pause there and pass the mic to Jack? Anything to add, friend?
No, I think you captured that brilliantly, and I already heard you mention sort of the discussion around imaging and things like that next, and so I will not duplicate that conversation, but I would say I'm right there with you. Yeah, I guess the one interesting question that comes up is like, do we even need the UA to decide on the imaging studies that we go to next? And I think one way to frame this, as you said, is like the likelihood of there being something in the renal parenchyma is so high that because of the coexisting erythrocytosis without an alternative cause. And so some people might say, oh, like, let's go straight for that. The other alternative is to say, gosh, is this a renal parenchymal source, a tubular source, or potentially a glomerular source of hematuria? And I think given that there's no coexisting kidney injury and really no other signal outside of the renal system yet, I think oftentimes we get the UA right away, but I don't know if a normal UA would change management at this point in time. And so I think, exactly as you had said, proceeding straight to imaging, even without these labs, and I think especially with these labs now.
Yeah, I love that. Thank you for bringing this up. And I think that's kind of the tension in real life, because this patient comes in and then you probably want to order everything right off the bat, right? And I think this is a great case that sometimes getting the initial lab can really, really help you in deciding where you want to image, right? Especially now with the polycythemia on top of someone who comes in with gross hematuria, and that you makes me worry about renal parenchymal, then you really would go, I agree with you, Jack, I would just do a CT abdomen pelvis with contrast at this point, versus without those labs, I would have perhaps thought more about a bladder etiology, in addition to thinking about, getting a kidney ultrasound. So that's such a good point, Jack. All right, Summer, back to you.
All right, so I'm going to start with the urinalysis, and I'm going to start with the color. The color was red, even though the patient had earlier stated that he was only seeing blood in the urine intermittently. Specific gravity was 1.023. The pH was 7.8, and urine was negative for glucose, ketones, and proteins. Blood was 3+. Epithelial cells were 2 per high power field, and the results came back negative for bacteria, leukocyte asteroids, and nitrite. And RBCs, we could see more than 100 per high power field, and white blood cells were present at only about 2 per high power field.
Jack, I've talked too much. Any comments on the UA?
No, I guess I would say the UA is valuable in terms of the hypothesis that it proves, and also the hypotheses that it helps really take off the table. I think whenever there's a syndrome of intermittent hematuria, we think about the sort of structural processes that can drive it, while keeping in the back of our mind the possibility of glomerular disease. And glomerular disease can be and I should say glomerular disease often, when it causes hematuria like this, we worry about the sort of rapidly progressive glomerulonephritides, which can have a crescendoing tempo to them, but may also smolder along for several months beforehand. And so with the initial tempo, right, the possibility of a few months of a smoldering autoimmune disease leading to GN is possible, that could be escalating now. We talked about how with the initial labs, the likelihood of a GN is rendered a lot less likely, because we would usually expect to see kidney injury associated with that. And it seemed like his creatinine was relatively normal. The UA helps us further decrease the probability of an underlying glomerulonephritis, or I should say of an underlying rapidly progressive GN at this point, because we don't see many of the other features that are characteristic of GN on a urinalysis. Those features being hematuria, proteinuria, and oftentimes a component of pyuria as well. And so we see here that there is hematuria wildly out of proportion to the degree of pyuria. And I think, if I have it right, that there was no protein at all that was seen. And we also don't see some of the other things that can clinch it. We don't see any RBC CAS either. The RBC CAS, when they're present, are helpful, but their absence doesn't take GN off the table. But I think in this case, the absence of proteinuria and the relatively modest pyuria, alongside very, very profound, both microscopic and macroscopic hematuria, I think really crystallizes for us everything that you had been saying already, Sharmin. So we can breathe a sigh of relief and just make sure that one of those diseases that can erupt systemically has become less likely, and really focus our energy on thinking about what the imaging may show, and potentially preparing ourselves for a negative imaging study, which would only make things a little bit more rich.
Beautiful. Summer, back to you.
All right, so I'm gonna move on to imaging. And what was done next was a CTAP, and it showed a 8 centimeter mass in the upper pole of the right kidney. But there was no evidence of spread to the lymph nodes, or to the perinephric fats, or to other organs.
All right. So, we see a mass, and, overall thinking about this patient who is coming in with like intermicros hematuria and with polycythemia, then you're really, really worried about RCC in this case. And to kind of think about RCC a little bit more, oftentimes actually people do, a certain patient population do actually present with iron deficiency anemia, but you can have paraneoplastic phenomenon with RCC, and one of them is EPO production that can lead to polycythemia. The other things you can see is like hypercalcemia, hypertension, and sometimes like I think we're like a little less likely you can get ACTH production, so you can get like Cushing's as well. And so in terms of like what to do next, I think at this point, most people would want that mass out, especially if you think about it's there's no other spreads, and you think this is a local reaction. The sooner you can actually remove the mass as a resected mass, the better the outcome would be. Jack, any thoughts from you?
No, I'm with you. I think the pretest probability, is, given the other lab findings that we see here, is going to be highest for a mass. And I also know that, is going to be highest for RCC. I also know that sometimes definitively saying whether or not something is indeed renal cell carcinoma can be quite challenging. Because of the reason Sharmin mentioned, oftentimes these tumors, once diagnosed radiographically, are treated with nephrectomy, the decision on whether we label it RCC or not can really require a lot of consternation, because unlike many other cancers where we secure a pathologic diagnosis beforehand, biopsying renal cell carcinoma carries some risk of potentially seeding the peritoneum after the biopsy is done. And so we're really left to rely solely on radiologic images to put that diagnostic label on, which is really saying we are confident enough that this is RCC that we think that the benefits of a nephrectomy outweigh the potential downsides of that. And there are some lesions that that are very characteristic and have the features, and we can say this is definitely RCC. There are other times where the mass can sort of sit on the spectrum between cysts and RCC. Oftentimes, cysts are relatively simple structures. They are well circumscribed, and the fluid that fills them appears to be relatively simple. And in those cases, we say this is a simple cyst. This is not RCC. But sometimes those cysts can transform and become hemorrhagic. And hemorrhagic cysts can look a lot like RCC in some ways. The fluid inside is complex. It's a mass-like structure in the kidney. And so the decision on whether this is RCC or not I would imagine involve potentially the discussion of both radiologists, urologists, as well as the general medical team taking care of this patient. And one helpful strategy that I've learned is that sometimes there is prior imaging that was obtained for completely different reasons that can help give us a clue into this. So if this gentleman had a CT abdomen and pelvis in the past, we may look back and then see, oh, was there a similar lesion in that same area? Cysts may have been present for a long period of time, and that may and we can see sort of how this mass may or may not have evolved over that sort of interval time period since the last imaging. But I think overall, Sharmin, I'm with you, right? We have a signature of disease here that's very compatible with RCC, but now the effort is to say, okay, are we sure that it's indeed RCC, or do we need to reach out to some of the experts to say, have we falsified the other things that can mimic it? Which the most common one that can mimic it is a complex renal cyst. If it is indeed RCC, there's another question that comes up, which is why is a 52-year-old person with relatively few risk factors for RCC developing this cancer? But I think the dominant energy at this point is to sort of get clarity on how characteristic or not the imaging findings are with renal cell carcinoma.
Yeah, I love that, Jack. I totally agree with you. And yeah, I was just thinking about the comment that you just made about like a 52-year-old getting an RCC. I feel like, 50s, if it was like much younger, I think you would worry about like genetic etiologies and syndromes that can present with RCC. As you get older, I feel like it just becomes more common. So I think he's in that age range of like, I'm like, oh, would you consider genetic testing in him? Or I think if I have to put my nickel down, like in someone who we don't see any other tumors or any other, like I think VHL is one that we worry about. Like we don't really see any footprints of that disease. I'm gonna say probably not, but I'm by no means an expert. So I'm curious to hear what you think, Jack.
Yeah, I'm not sure what I would do. I think in how do we say, like, I think how to approach genetic tumor syndromes. I'm with you. I think 50 is not incompatible with the base rate of cancer. And in the absence of other coexisting tumors. So I think like if I look at it through the lens of this patient, I don't know that we would go digging. The only sort of counter argument that I've heard from that is like this gentleman may have 18-year-old children or very young children who may want to know that information. And that's where, like, I think there's some cases where I've been like, we really should do this testing because it'll be helpful. There's other cases where it's like, we really should not do this testing because even if the results were positive, we wouldn't know what to do with it. And I think this is a situation where it would be like, this may not necessarily change things for you, but the question may be invoked for your current progeny or your future progeny if he is still thinking about having children. So I think that's probably the like general approach that I would take is like would fall sort of in the let's talk about it bucket. But I think, yeah, because there always is the risk as you were saying of opening up a Pandora's box there. So yeah, I think without having solved this exact dilemma before, I think that's probably the approach that I would take.
Oh, that fantastic. I love the idea of like in terms of like thinking about a family history and the children. That I was not thinking about that, and I totally agree with you. Awesome. Summer, back to you.
Yep. So what was done next is a nephrectomy. Usually when a mass when a mass is found on abdominal testing, a renal mass, usually if it looks neoplastic, we directly go for nephrectomy, either partial or radical. This depends on the how big and how spread out the tumor is. And here the patient qualifies for partial nephrectomy, which was done, and post-surgical pathologic report was performed, and it showed basically a clear cell RCC, an 8 centimeter clear cell RCC with a sarcomatoid differentiation.
Wow, such a great case, Summer. Thank you so much for bringing this to us. And I love the fact that, you know, this is something that we think about, like hematuria, gross hematuria, like polycythemia, like all these schemas that we use often in clinical medicine. So I really, really loved how this case highlighted. And I feel like with RCC, a diagnosis that we should know all well. So I really deeply appreciate you presenting this case. And just out of curiosity, did you guys think about like any genetic testing, or was it thought to be like kind of age-related cancer?
So we didn't do any genetic testing on the patient, but as any tumor, it was sent for a somatic for genetic testing. So a non-panel was done, and usually, especially clear cell RCC, up to 90% of the clear cell RCC tumors will either have a mutation or hypermethylation of the VHL, which is usually what is behind the tumor developing.
Awesome. Thank you so much, Summer. It's so nice to meet you. Thank you so much for being here.
Thank you so much.
Get to learn from you more. Thank you for presenting. Jack, any thoughts?
No, just gratitude for you, Summer. Thank you so much for bringing this case. You know, I think it's such a powerful example of how a relatively bread and butter chief concern, a relatively well-known diagnosis presenting in its known way. There's still so much learning and so many management decisions to be unpacked along the way. And I think the power that lies in mastering the basics cannot, at least I find sometimes will overlook it relative to the rare diagnoses. I think this is such a great example of how there's so much to learn and so many different contours and nuances in these common presentations and common final diagnoses. So thank you for bringing this to us today.
Thanks for the opportunity, guys.
Awesome. Thank you so much. Trias, we're ready for you. And shout out, Elena. Thank you for scribing.
Sure. Thank you, Summer, for this wonderful case. So I'll just be summarizing some of the teaching points for today. So we had a 52-year-old male who presented with intermittent gross hematuria, and like Sharmin taught us that some of the important things which we're supposed to think of are, number one, medications and any underlying hematological disorders. And also we can take a systemic versus a localized approach towards hematuria. We can think about pathology within the kidney, the ureter, the bladder, urethra, and prostate when we're dealing with this. And when we think about hematuria, it's also important to rule out some of the mimickers of hematuria. Things like vaginal bleeding in a woman, and pigments like rhabdomyolysis, hemoglobinuria, or porphyria, and also beetroot ingestion. And as we proceeded, we also learned that the patient also had right flank pain accompanying his hematuria. So when that comes into the picture, we generally think about two different types of causes. We can either think about a kidney pathology, where we, again, further, we can divide it into glomerular versus non-glomerular. And when we think about glomerular etiology of hematuria, it's generally more of a microscopic picture rather than a macroscopic picture. And when we think about glomerular hematuria, we're also expecting things like proteinuria or RBC casts, although RBC casts are not always seen, but sometimes we do expect it. And when we think about the non-glomerular etiologies with a kidney pathology, we think about pyelonephritis. And then here we also think about RCC and polycystic kidney disease. And we also should not forget about causes about the bladder pathology, for example, urothelial cancer. And so when we are dealing with hematuria and there's no good localizable systemic findings, a good physical exam is of paramount importance, and things that will help us take us forward in the diagnostic journey include urine analysis, an exam directed towards looking at signs of bleeding, because we don't want to anchor too prematurely on a local urological cause and miss a systemic cause of bleeding. And also things which will help us move forward include CBC and INR. And with respect to imaging, really depends on what we are thinking about. For example, a kidney ultrasound will help us to look at if there's probably a renal stone, or also if there is hydronephrosis. And it's also important to consider urology consultation and cystoscopy. And also, we learned that whenever there's a person with gross hematuria to such an extent that it is ultimately leading to anemia, it's also important to first make sure they're doing well with respect to their vitals. And orthostatic hypotension can also be there if a person is significantly volume deficient. So first, stabilizing a patient is always the useful approach. And as we proceeded, we learned that the patient had a hemoglobin of 17.4. And then we thought about polycythemia and an approach to polycythemia. And a useful approach would be first to make sure we're not dealing with a polycythemia mimic, which could be because of a hemoconcentration. And we could also think about the two arms of the polycythemia, which can be EPO mediated versus non-EPO mediated. And when we think about EPO mediated, it's generally something which is causing a hypoxia or a chronic hypoxia, and then which stimulates the tubular cells of the kidney to produce EPO, as in the case of obstructive sleep apnea. Or sometimes it need not be mediated by hypoxia. It can just be a paraneoplastic manifestation of RCC. And sometimes any kidney pathology, which, for example, a very large cyst burden can also compress upon the renal parenchyma and cause a localized hypoxia, which can also stimulate EPO release. And when we're talking about the non-EPO categories, we're generally thinking about malignancies like polycythemia vera and the other myeloproliferative neoplasms. And so RCC can also produce a lot of various types of paraneoplastic syndromes. And so that's a very great mimicker in medicine. It can produce hypercalcemia, it can produce Cushing syndrome, which is also ACTH mediated. And it becomes extremely tricky when we are trying to biopsy an renal cell carcinoma, which is typically avoided because of the fear of seeding tumor. And like Jack mentioned, the only way which we get a final pathological diagnosis is only after we perform a nephrectomy. And we had a young patient, a relatively young patient, presenting with renal cell carcinoma. And an important question which arose was whether or not to pursue genetic testing. And like Jack taught us, it's important to individualize these discussions and have a good pros and cons discussion with the family at the bedside. So those are my teaching points I have. Thank you.
Wow, that was amazing, Shreya. So the fact that you're doing that at 2:30 a.m. just blows my mind. Thank you so much. That was fantastic. Again, thank you so much, Summer. Thanks, Elena. Thank you to all of you for joining us, and to Jack. It was always a pleasure. We'll see you tomorrow. Have a great one, you all. Thanks again.